We tend to talk about the back pain as just about your spine, a disc, a scan. But if that were true, imaging would give you answers. And most people with chronic back pain would already be better. Chronic back pain isn't just a physical problem. It affects how safe your body feels, how confidently you move, and how much of your life you slowly start to shrink. When pain lasts, it's often not because the body is broken, but because the nervous system has learned to protect. And until we look beyond the spine and start treating pain as a whole person experience, people stay stuck searching for fixes that never come. Today, I'm joined by Professor Deepak Ravindran, an NHS consultant in pain and lifestyle medicine, honorary professor at Teesside University in the UK, author of the Amazon best-selling book, The Pain-Free Mindset, and a member of the World Health Organization FIDES network. His work focuses on helping people understand pain differently and what it really takes to move forward again. Just a quick note for the listeners, I'm recovering from a recent cold, so my voice is a little husky today, but I'm really looking forward to this conversation. And Dr. Ravindran, thank you so much for accepting my invitation to this show. I am so excited to have you here.
Thank you, Bernadette, for having me. It's a pleasure again to be talking to many of your listeners, and I love sort of conversing when I get invited to podcasts in the US because I think there's so much more opportunity to understand pain and the new science of pain. And I see so many of my colleagues in the US getting that kind of fantastic success with this message being sent across to the general public. So I'm just really happy to contribute to that conversation here. So thank you for having me on your podcast.
Thank you. You mentioned already new science. Can we talk about that? What does it mean?
Good point there. Good catch, actually. Excellent. Well, the whole thing is all medical professionals who are right now in their 30s or 40s, the knowledge that was taught to us in our healthcare schools, whether that's a physiotherapy school or a medical school or a dental school or whatever it is, nursing school, that knowledge is completely outdated. That knowledge was prior to understanding of the presence of what the spinal cord, the neural circuits in the spinal cord and in the brain, and actually the decision making process of the brain and the associated circuits and various centers. This was not information that was really taught well in medical schools. This was just information that was not even in the awareness zone of most of us until scientists and technology kind of caught up in the early 2000s. And so therefore, it's only the last 15, 20 years that we've made a better sense of understanding the new science. And this is what I'd call is the new science, which is now starting to become consolidated. It's now making its way to the guidelines of many main organizations of the pain world. So, for example, the International Association of Study for Pain, which is a US-based organization, which is like the torchbearer for all pain-related stuff in the world, finally updated its definition for pain after 50 years in 2020. And they were very keen to introduce this concept of pain and nociception being different phenomena. And what this means is that nociception is the word that we use for biological signals and chemicals that are released at the site of an injury or a fracture or a fall. Those chemicals that get released when you have an inflammation or a swelling, those are just the chemicals released at the site where you've had an injury or a surgery. That's not automatically pain. Those chemicals then have to change into electrical signals into the nervous system. Then those electrical signals have to travel in the nervous system to the spinal cord first, where they have undergone some change, either they are turned up or turned down by various junction boxes in the spinal cord. I'm simplifying the science a little bit, but that's what is essentially happening. And then that signal goes to the brain. And by the brain, we were taught in the 90s that there is a pain center, there's one set of circuits, and then this information goes from one point to another point to another point, and these were called the pain centers. But now we know that's different. The signal arrives at the brain, and this electrical signal then is interpreted by the brain. The brain says, okay, where's the signal coming from? What am I doing when the signal came? Have I experienced the signal before in the past? What have I done in the past to protect the organism? If I've never experienced the signal before, if it's the first time, should I protect anyway? Or do I know if some member of my family or someone on TV, someone on radio, someone on another podcast, some social media influencer, if they have experienced a similar signal, what did they do? So the brain kind of looks at this incoming electrical signal and in a matter of milliseconds makes a prediction. It already makes a prediction, kind of saying, this is what I'm anyway going to do to protect. And then it will process the signal. And if the sum total of all this decision making of prediction and processing is, I need to protect, that is when the brain will say, okay, I need to protect all sort of missions on standby. Everybody go into lockdown. The muscle goes in lockdown. Let us bring about the experience of pain. And that is what we mean by pain and nociception being different. And this is all part of the new science where we're actually saying pain is not just a bottom up phenomenon that the moment you feel pain, it's one part of the body and it's always that part of the body. It actually means that pain is a emergent output of a decision making process by the spinal cord, by the brain, by lots of signals that are coming from the body and inside the body. And that output that finally comes is the experience of pain, which means in some ways our reliance on only the body is not the right thing. But in a different way, I think the opportunity for neuroscience, for a lot of clinicians in this field, and for patients is that we can now think about giving hope from relief from chronic pain, and recovery can be achievable, but we need to start from a different vantage point because the new science tells us that recovery occurs by a different set of measures than just thinking of it in the old traditional way, which is let's look at which part of the body should we scan and what do we do about stabilizing the body.
For the listeners, how would they know if their doctor is following the new science or the old science?
Oh my God. Well, this is really the toughest thing for most of us as patients, isn't it? And the reality, Bernadette, I think it's quite difficult. I must say that when I talk about this new science, and I have to be frank that if the organization, the torchbearer and the flag bearer has brought this definition out only in 2020, and in the United Kingdom, our guidelines nationally in the UK changed to reflect this new thing in 2021. When I go and talk to patients locally, when I engage with the community, when I talk to other healthcare professionals, this is still brand new information. This is still information that they have to make sense of because they've been taught for 20 years slightly differently. That behavior change, that belief change is going to take time. I think it requires repeated understanding and listening to the information. So, in that way, I'm glad that I'm given this opportunity to come onto your podcast to explain to your listeners, to listen, to sort of allow your audience to hear this. And I think in the United States right now, there are a lot of healthcare professionals who are speaking in this new language, this new neuroscience. There are people on the West Coast and East Coast who are doing this. So I'm sure that if your listeners can listen to these messages, maybe listen to other podcasts and other people like yourself and other professionals, over time, I would hope that and by over time, the research indicates that from the time some research is written about and published in the academic paper to it being available at the coal face to the patient can take as long as 10 to 15 years. But this is before the social media age. This is before the age of internet. It's a lot shorter now. So I'm hoping that this information that we are talking today now will become more useful clinical practice within the next couple of years, hopefully. Until then, well, actually, let me finish the point that you started with. How will your patients know whether the doctors knows or not? Well, I'm hoping that they listen to this podcast. They'll go away and maybe look at some of the resources, read my book, read a couple of references that you might put, and they might actually go and discuss with their doctor and say, do you know this? What do you think of this? Can you help me recover? Can you give me the hope to make sense of what I'm doing and help me do it better? That's maybe the conversation we can help our patients have.
If someone has done the scans, the physio, the rest, and they are still in pain, what is the one thing they are missing that no one has explained to them?
Well,
Usually.
usually. I think the biggest thing I find is that my patients often hold on to the underlying unspoken belief that their pain means some damage is happening in their body somewhere. That is the biggest worry, that's the biggest fear, and that is almost their unspoken belief. And I think the best thing we can do as healthcare professionals is that validation piece, is that listening to the story. And then when the scan is done, it's not about telling them, a lot of times my colleagues here in the United Kingdom, they often make that error that, oh, the scan's normal. Let's tell the patient, oh, the scan's normal. Good thing it's not coming from your disc or a joint in your bone, but we don't know where the pain is coming from. That's all right. Just do a bit of exercise. It'll be fine. That really doesn't help, because if I were listening to that and receiving that message, I'll be saying, well, where is the pain coming from then? So unless and until I, as a patient, do not receive an explanation that feels logical, that feels scientific, that feels acceptable, my nervous system is not going to feel safe. It's going to feel that something has been missing, because if the scan hasn't found it, but I'm in so much pain, what's been missed? And then that is a unspoken fear. So I think that when you can reassure the patient that, look, we have done a scan and we know that the scan shows an age appropriate change. But this means that if the scan, i.e., the bone or the joint or the disc or the nerve, doesn't look squished, everything looks within normal range for that age, then that means that this is likely to be either because a soft tissue has been stretched or changed, and that may not be visible on the scan, a muscle may be in spasm, but a spasming muscle doesn't get seen on a scan, or the signaling inside the nerve may have got increased or chaotic, and that again isn't going to be seen on the scan. So it doesn't mean that you are actually making up the pain. It just means that the present technology doesn't pick up or look inside the nerve signaling, doesn't pick up a tight muscle. So let us look at the strategies that is required to relax a tight muscle or reduce the signaling and the sensitivity in the nerves. That is probably the unspoken message that our patients want to hear, so that they can then take the next step, knowing the nervous system is safe and it can allow you to take that next step.
I love your approach when you said age-related findings like disc degeneration. Let's talk about that, because we know when I was in my 20s, I had chronic back pain, and this is why I do what I do now.
Okay.
My mom had back surgery, an anterior lumbar fusion, which went bad, and it became a life saving surgery back in 2011. But she recovered. which is good. And she's now exercising and lifting and squatting and all good. So age-related findings, disc herniation, as we know from research that it can be normal as we age. They are like wrinkles on the inside, and also disc degeneration. We have more as we age. Am I correct?
Absolutely. And the fact that disc bulging or disc dehydration or disc thinning can happen in people with no pain was the result of a study that was only published in 2014, Bernadette. So it's just 10 years ago that the first study was published where they looked at people who were having no pain, did an MRI scan of their neck and their backs, and they showed that 80% of the 50-year-olds in the study had disc degeneration, meaning thinning of the disc. 60% of the 50-year-olds had disc bulges, and they were in no pain whatsoever. This is how new the study is, and it is only since then we've had studies that have been done on MRI scans of people who had no pain of their hips, of their knees, of their shoulders. In fact, in the study of the MRI scan of the knees, 43 out of the 44 people in the study had a meniscal tear and no pain. 69% of the people who had MRI scans of their shoulder had a labral tear, the cartilage
Yeah.
tear, and no pain. These all studies happened between 2011 to 2019. It's only in the last 10, 12 years that we and surgeons and the general population have now had to explain and understand and accept that you can have changes due to age in many joints and cartilages of the body, but pain need not happen every time, and that there is no correlation between pain and the kind of structural changes that you have in your body.
So they can be a contributing factor, but it's not the cause, right?
So the only times that they are contributing is when there is a congruent or concurrent pain that comes. So you have a fall and your knee gets swollen, and they do a scan or x-ray at that time and they pick up a meniscal tear or a bucket handle tear, then you can say yes, these two correlate. But if you had generally developed a gradual onset of pain in your back or your shoulder or your neck or your lower back or your hip, and then you go for your scan and somebody tells you, oh, you got arthritis in your hip, or you got facet joint arthritis, or you got arthritis in your shoulder, the challenge is we can't say that all of the pain is only from the arthritis in the shoulder, because that may have been happening for 1 or 2 or 3 or 5 years onwards from the time, but your pain may have only started 1 month or 2 months before. Arthritic changes may have been there for a few years prior. So all I would say is, in that situation, the explanation to the patient should be, we discovered that there are arthritic changes or thinning of the cartilage, etc. here, there. It could be one of the causes, but let us look at the rest of what's happening in your body. What has changed for this symptoms to come on? Have you been exercising less? Have you been moving more or moving less or overdoing something? Are there any other stressors in your life? What else could be contributing to your nervous and immune system becoming sensitive? That should be the wider medical history that we should be taking, rather than just doing only a musculoskeletal examination and confining our findings and treatments and plans just to the musculoskeletal examination.
About 15 years ago, we were living in Australia and I was dealing with chronic back pain.
Right.
Living away from the family, another culture. It was tough.
Yeah.
But anyway, I had really, really good doctors who were helping me, and Pilates and other things help me to recover.
Yeah.
Mindfulness, managing stress, sleeping better. On the other hand, when my husband has a business trip, suddenly, I feel my back a little bit, you know. And I do know why. More falls on me, on my shoulders. You know, he's away
Yeah.
for a week or two. And I realized, now I know why. I sleep less, I do more.
Yeah.
I don't have time to do the things for myself, taking a hot bath or reading a book or go for a walk, because I don't have time for it.
Absolutely.
So now I know why do I have a flare up, which
Yeah.
is very, very interesting. Have you experienced back pain?
Yes, I have intermittently. Probably in the last 5 years, I've had about once a year, I have an episode of back pain where it has often been, and I almost understand the triggers now. In my case, the first time it happened, I had an MRI scan done. I was in India at that time, so I had an MRI scan done of all of these of my back, and I have age related changes. Now I'd call it that, but the MRI report said I have got L45 and L5S1 disc degeneration with narrowing and some mild spondylolisthesis, so a slight slip of the L4 over the L5, and with facet joint arthropathy. So those are my findings for my lower back. But at that time, all I wanted to know was, well, is there any significant radicular or any nerve compression symptoms? And it wasn't. And so, yes, so I understood it after the first session or the first year that I had the scan. After that, every year when I get it, I can know that it's because either it's coming towards winter time, or I've actually eaten a bit more, not exercised that much, been a bit more stressed out. I can see when all of those things dovetail together, I can look back and say I've overdone it. And that usually, so for me, it's often a soft tissue problem right now rather than a structural thing.
So if scans say nothing's wrong, why does the pain still feel so real and so frightening?
Absolutely. I mean, pain is real. There is no doubt about it that our listeners, the people who are struggling with chronic pain, it is very real. And I go back to how I started this podcast talking about this distinction between pain and nociception. You might say that, okay, the disc bulging or the disc dehydration or disc or arthritis in your facet joints, they could be contributing to some of the biological signals. But that biological signal, when it comes to the brain and that then takes the nociceptive signal to the brain is receiving input not just from this signal, but it is also receiving input from the immediate various other parts of the body, the skin, the muscles, the ligaments, other bone structures. It's receiving information from inside itself. So the gut, the microbiome in the gut, the immune system within the intestine. So it's receiving information from there. It's also receiving information from the outside world, whatever is close to the body. So our immediate family, our immediate society, our immediate newspapers, the internet, the wider world. And the purpose from an evolutionary, so again, I come from a very evolutionary look at things. The evolutionary purpose of our brain is that it acts like the CEO of our entire body, and it actually says, what do I need to do to protect? Where is the threat and the danger coming from? And how can I make calculations to ensure that I keep protecting the right amount? So every bit of information the brain is taking in from the eyes, from the nose, from the ears, from the skin, from the inside, is geared towards saying, am I doing the right things to protect and ensure that this person lives for as long as it needs to live, or he or she needs to live? And that means that when that signal from a painful area or nociceptive area arrives, the brain is not just looking at this nociceptive signal, it is also integrating all the other information it comes into the same set of nerve circuits. And sometimes it does not get the accuracy spot on. It would rather predict and overprotect than to take a chance and say, you know what, there's nothing to bother about, I can just chill out. Because that could mean potentially harm or danger to the organism. So it would rather overprotect. And that means that there can be a manifestation of extreme pain in one area or many areas of the body because the brain and the nervous system and the body has made a decision that protection is far more important, because at least if you're in pain you're going to seek attention, or you're going to move less, or you're going to hide away or stay away, and that means you get to live longer. It's a flawed logic by the brain, by the nervous system, by the decision making process, but at least its survival benefit is there. And that is what happens, that you may not have a significant change in your structure or in your scan, but the intensity of pain can be so bad that you feel, oh my God, this is something really horrible. And I always have this set of 5 questions I ask my patients to ask. If you are having a flare up of your pain, or if you're suddenly having a massive increase in the sensitivity and pain, then have you had a recent fall or injury? If the answer to that is no, then the second question is, have you got any localized presence of inflammation or fever in the area of the pain? If the answer to the first 2 questions are no, then that means this is a nervous system that's oversensitive. And therefore, the next 3 questions should be, have I overdone anything in the last few days? Has my diet or my sleep or my stress changed in the last few days? What is actually making my nervous system go on overprotect, or my immune system go on overprotect? Those are the 3 curiosity questions that I encourage my patients to always just take that extra moment and ask if the answer to the first 2 questions are no.
So for the listeners, I do believe with the first 2 questions, you actually ruled out the red flags, right?
To a great extent, they rule out most red flags. Are they 100%
Coda
accurate in
equina,
everyone? Well,
yes.
it will pick up, isn't it? For example, Cauda equina, if you're right, you're not going to have fever or swelling, but if you're going to have sudden weakness or loss of bladder or bowel, then I would say that that's a big change. I'm hoping that in most of the Cauda equina cases that I have seen in my lifetime in the UK, practicing here for the last 20 years, I've had just one or two, and both times the patient has had a fall or some kind of trauma that triggered everything off. Now, could it happen without anything, suddenly the disc popping out to the extent that it completely squeezes the nerves? I'm not sure. Maybe it's been reported in the literature, but I don't know for sure.
So I told you about my mom. Before she had the surgery, tried physical therapy, and they used this big Swiss ball. And she had to sit on it. And she told the physical therapist she doesn't feel comfortable and confident. She wants to get off the ball. But the physical therapist insisted, no, this exercise is good for you. She felt something, and then after that, she could barely get up, and she had Cauda equina.
Right.
So we took her out of the hospital in a wheelchair.
Wow.
So I'm not sure if physically anything changed. You know what I mean? I'm, sitting
There's
on
no
a Swiss
history
ball.
yeah.
No.
Yeah.
But that's why, as a clinical Pilates instructor, listening to my patient, if that exercise is within pain tolerance and it's okay, is very important. I think communication is very important.
Absolutely.
And to trust your clinician or physical therapist. And if the patient tells you that they are not comfortable, I think we need to listen.
Absolutely. I think that in all of this discussion here, the biggest thing that I come back to now as a pain coach, as a communication specialist, as behavior change educator, my biggest advice to a lot of my healthcare colleagues, my juniors, my trainees, is you have to give the time to completely listen to the story. Because if you can give that 5 to 7 to 10 minutes of the initial consultation to get the full story, you will be able to pick up everything that you need from the patient. They will tell you, and you will know whether there is something that is just, with experience, you will get that radar going up where this isn't fitting the pattern and this requires a bit more testing, investigation, scans, examination. That comes with experience. But the initial pieces of training, the years of training, the best way to get to fine tune that radar of yours is to just listen to more stories, more patient experiences and narratives.
Do people actually need to fix their body to get out of pain?
No, I think the research now indicates that fixing the body sometimes can become a exercise in focusing too much on one part of the body, wanting to make it strong, or conditioning, or toning, or strengthening. These are often common words that everybody uses to keep repeatedly going back to any form of support. And my view is, I think when I talk to my physiotherapy colleagues, Pilates colleagues, I value them immensely on the support they provide to the patient. In the UK, we are moving towards the point wherein we are saying, what can we do in every consultation to empower the patient? What can we do to improve their confidence and their self efficacy in looking after themselves? So I think every time, and I feel physiotherapists and movement instructors, they sometimes have the biggest amount of time to give to the patient, compared to primary care physicians, both I think in the US and in the UK, where you
Absolutely.
get only about 10 or 15 minutes. A physical therapist or any massage therapist, a movement specialist, an osteopath, they usually have 30 to 45 minutes to an hour on the first consultation, which means you have so much time to actually listen to the whole story, make a difference, make them or work with the patient to do movements and show movements that are safe, that are reducing the fear, that are giving them the confidence. So I feel that every occasion that we spend with the patient should be an occasion to improve their self efficacy and their confidence in their body. And that fixing the body doesn't mean you're actually making a structure necessarily better. That may be a good thing to do, but along with it, can we provide safety to the nervous system as well, which is still part of the body? I think everything is a part of the body, even the brain is part of the human body. So, fixing the body in the sense is also fixing the nervous system, retraining the nervous system, providing safety to the nervous and immune system. That I think is the responsibility and the challenge and the honor for every healthcare professional.
I experience in my personal practice, I help mostly women overcome chronic back pain. And we start our program, and then everything is going smoothly. And then after a couple of weeks, they have a flare up. And they completely back off. They shut down. Can you give me and them an advice how to deal with that?
So, part of my management strategy for flare ups is, first of all, in the first consultation or even on follow ups when they come, I tell them that with chronic neck pain or back pain, flare ups or setbacks, whichever word, flare ups often from a human cognitive perspective, flare up feels like a strong word, whereas a setback has a slightly safer feeling. What sounds a little bit more safer to the nervous system? So, off late, I have leaned towards the word setback because A setback means it can be something you move forward from. A flare up might often feel overwhelming. So that's the first part there. So when talk to patients, I actually tell them, look, a flare up or a setback, it's not a question of if it happens, it's a
When?
question of when it happens. And that means that if we know that it is likely to happen and you cannot absolutely micromanage and control to prevent it from ever happening at all, then what is more important is, can we both help to create a toolkit for you which you can practice in advance, so that when the flare up happens, you know what to do and you can get to doing it quickly. So I give the example of learning how to drive a car and learning how to put the emergency handbrake on. You don't want to find out where the emergency handbrake is when you actually need it or when you're about to hit it, because you have to work at automatic control there. At that time, you don't have the time to say, this is where it is, this is how you learn to put it, this is what you need to pull the brake towards you, and this high. It should come automatic. You don't have the time in an accident situation. So the same way, you learn how to put a handbrake in a controlled environment where your driving instructor teaches you these are the circumstances in which you pull the handbrake, and gets you to practice a couple of times so you feel confident. So that when it actually requires, it becomes a little bit of a second nature to you. And that is what I tell them is, let's now look at what could be the components of a toolkit for you for handling a flare up. And I have in my book, I write about the RAD approach, a RAD toolkit, which is RAD, means that can you have a couple of activities from the relaxation bucket? Can you have a couple of movement based strategies? So, activity A is the activity, and can you have some approaches from the distraction bucket? So, relaxation might be some breathing techniques, some stretches, some gentle movements. Activity might be, again, some movement based tactics there. Distraction might be listening to music or some mindful thinking away. The point is, can we have 4 5 things which they may have done and bring it together and say which are the ones they like, which are the ones that feel safe to the nervous system, which are the ones you'd like to practice and start to do them comfortably, so that when you have the flare up or setback, it comes automatic. You get into that breathing mode. And as long as, again, we go back to that first 5 questions, if there isn't been an evidence of a fall or injury, and you're not having any sudden loss or weakness or heaviness or something unusual out of the blue, and you don't have any fever or infection or inflammation, then bring the RAD toolkit to setback management and be confident or reassured that you're not missing anything. Sometimes that is where they may need that little bit of support from a healthcare professional who can just reassure them and say, okay, you're not having anything sinister that requires another investigation or anything. Just focus on the toolkit. Let's help you through that. And that's where I think colleagues like yourself, colleagues who are in the osteopath, certainly in the United Kingdom, I find that this is where physical therapists, massage therapists, acupuncturists, osteopath, chiropractors, these have the best value because patients can get to them much quicker than a primary care physician or a secondary care specialist.
Yes, but unfortunately, sometimes they get the wrong information. Like they say, oh, they say that your pelvis was out. And what do? Do I just nod my head? Yes, no, your pelvis cannot be out. Physically, your pelvis and your spine is a very stable structure. So at what point do you tell the client that, or your patient, your pelvis is very stable structure and nobody can actually put it back?
Yeah, it's a very interesting part is there, Bernadette. I certainly, if I'm seeing the patient for the first time and they have gone to a healthcare professional who has given this kind of misinformation or slightly outdated scientific information like a pelvis or something out of place, then I've got to take into mind that they may have seen that healthcare professional a few times before coming to me. They may have a belief system or a trust factor in that healthcare specialist, and I am seeing them only for the first time. While I may be a medical doctor and may carry a better authority and trust, in their eyes, I'm still a first time person for them. So I'm very mindful that I don't as yet have the rapport or the trust that I would need to change their beliefs. So I would only focus my consultation to actually say, okay, you may have been told about a pelvis being out of alignment. From my understanding and my working with surgeons, I know that often that is quite tricky to prove. I know that that specialist may have had his own experience or her own experience. I'm not so sure that I can actually demonstrate it. But equally, from a medical specialist, no surgeon or pain consultant is going to put a misaligned pelvis back. There doesn't exist any intervention or surgery for it. So let us focus on what we can do. If you feel that the pelvis is not in line, is it straining the muscles? Is it putting pressure on the soft tissues? Is it sensitizing the nervous system? Can I help you calm that muscle down? Because it's possible that if there is a tight muscle, that may also be exerting forces. So, my desire at that time is to try to still make logical sense to them to win their rapport and their trust. Because changing practice or trashing somebody's beliefs when they are at their most vulnerable does not work every time. And in some ways, why should we want to? Because we don't know that other healthcare specialist, what were they trying to say? We only know the patient's interpretation of that. So I'm always cautious that I'd like to find out and work and align myself with the existing beliefs of my colleagues and my patients rather than completely throwing everything out of the window in the first consultation, at least.
Good. Thank you for that. Now, can fear and constant checking keep pain going even after the body has healed?
That is a really good question. And often that is a concern that a lot of my colleagues, and including I, have when we are having these days wearables and trackers for a variety of things like sleep or for food. A lot of these things these days, trackers seem to be the way ahead, and wearables seem to be every time talked about, because the view of all the people from the management world and from all these business chaps is, if you have data, then you can manage it and do something about it. That means you need to be constantly checking and monitoring. My ambivalence towards it, meaning my concern about it, is that in some people, that level of constant monitoring and checking and fear is in itself giving the nervous system a message of threat, that I have to keep constantly checking because otherwise it will go wrong. That means it keeps your nervous system in a state of hypervigilance. And so that, I feel that kind of constant checking and scanning, and if you can do it without worrying, that's a good thing. But when most of the time you're constantly checking and fearing and worrying, that means it keeps the brain in the threat mode. And that means in mechanical back pain or neck pain, even if the tissues have healed after an injury, the nervous system hasn't received the memo. It keeps telling the brain and it keeps instructing the whole muscle system to say, stay on alert. There's still probably some danger. Let's have a low threshold for going into lockdown. So the pain ends up being there because paradoxically, you're checking it all the time. It is never getting time to feel safe to carry. So I feel that monitoring or checking is a double-edged sword. In the right person at the right time, checking and monitoring and wearables are useful. For a lot of our patients, it's a little bit more nuanced. And certainly in the case of back pain or neck pain, if I find that the person is prone to hypervigilance, has got a history of anxiety or mood changes, then I really work on trying to reassure their nervous system and safety and move them away from constant check ins.
What belief do you see holding people back the most, even when they are doing everything right?
I think I will go back to the one that I said, that belief that pain equals damage. That is the most common belief that I see people holding on to. Even my closest friends, right now, one of my closest friends is having a back pain issue. The belief is often that there are parts of my body or my spine that have got degenerate or arthritic, and this is how it's going to be. That is the belief, that fear that the structure is the one that's causing it. And I think if we can show all this evidence and try to help people to feel confident in their body once again, that there is no connection between pain and injury and tissue structure, that their body is not broken, then that is where the penny drops. That understanding and that relief doesn't really need to come from doing more and strengthening, but it is about saying that the body is not fragile, the body is strong, and that I know I feel safe.
You're part of the World Health Organization FIDES network, which focuses on health literacy and fighting misinformation. For someone with chronic back pain who feels confused by conflicting advice, what should they actually trust, or who should they trust?
So, certainly in the UK, we have got the Academy of Royal Colleges in the UK tries to endorse every doctor who is going on social media with their channels. So we know that that kind of doctor is going to be giving out trusted information. I think with back pain, especially since your audience is in the US, there are a number of valid resources. Obviously, you've got the big centers in different parts of the US, the medical health centers that are generally very spot on in terms of giving good quality information. Outside of that, I think there are some really excellent researchers who are doing some good work. People like Howard Schubiner, Dave Clark, Nicole Sachs. They come from this understanding that when you have stress or trauma, then that can be a powerful information to your nervous system that there is threat, that there is danger. And that can be a big factor for the maintenance of chronic pain. So I think they are all good sources of information there. Otherwise, I would suggest that the International Association for Study for Pain, the IASP, that has a lot of patient friendly leaflets, which again is good, trustworthy information. And then, of course, there are the content creators like yourself who have taken the pains to educate themselves on the new neuroscience, are doing so much more for your own audience and your patients. So I think it's in connecting the dots in the community. We have to do more, and as a FIDES member, WHO FIDES member, our big push around health literacy now, especially for a condition like chronic pain, is how can we improve the public health understanding? How can we work with our communities to ensure that this information is scaled down right at the community level, so everybody's information base is changed for the better?
Your book lays out a 7-step framework to help take control of their pain. For someone who's exhausted, overwhelmed, and doesn't know where to start, what's the very first step they should focus on?
So A really great question, actually, because when I wrote that 7 step framework there, it was more about broad treatments that people should have when they are looking at pain management. I didn't want people to get stuck thinking about which drug should they take, or can they get an injection or a surgery. I didn't want them, because that is often the traditional understanding is, if you're in pain, you should have a scan, and then immediately there should be a tablet, a painkiller, or they should look for an injection or a surgery to take away that pain. So it was a very structure based treatment paradigm that we traditionally had and still have. And my book essentially just expanded that to say that when the experience of pain comes, so for nociception, where there are biological signals, the medications and interventions work. But for the experience of pain, we needed to have an understanding of the neuroscience, of the contribution of diet and nutrition, of sleep, of movement practices, of mind body techniques. So that is what my book was all about. When we think about then what is the first step, my suggestion to most of my patients is not necessarily to say, what about fixing that or stretching this or strengthening that. My first step is, can I help you understand it? Can I help you make sense of why you're experiencing that much pain, and what are you afraid of? So that understanding piece, and understanding that the pain is very real, yet it is not necessary that it is a part of the body. That, I think, is the first step that people should try to do. And often it can feel very difficult to do when you're struggling in the intensity of pain. But if I can just, maybe I'll be happy to give them a medication. But can I help you understand what your pain is? Because once they can get that shift, that one shift alone can reduce the fear, can give the nervous system some breathing space, can help the immune system take down the threat defenses by biological chemicals. And that is where I say, start by learning how pain works, because clarity gives you confidence, reduces the threat. And when threat reduces, the body often starts to make and begin that change, and you've not done anything else at all.
That's the next one. You talk about pain and just being in the body, but so how the body or the brain perceives the threat. So for someone living with chronic back pain, how does that show up in daily life, and why understanding that is so important?
Really important question. And realistically, I would probably paraphrase that wonderful book by Bessel van der Kolk called The Body Keeps the Score. So when you say, how does that pain show up? How does the threat response show up? It will invariably show up in the body. And the body, by body, I mean it can show up as a tightness or a tension in different parts of the body. It can show up as poor sleep. It can show up as hypervigilance, increased anxiety. It can show up as reduced movement, or a bracing response where everything just goes tight, part of that overall
Yeah.
tension. And that's when everyday activities, simple movements start to look risky, because everything is now a decision by the nervous system and the immune system that this is a threat response. And that means that you have to do something different. And this is where I say, well, instead of fighting that body, how about starting to work with it? Instead of asking, what's wrong with me? How about changing the question to saying, what is my nervous and immune system trying to tell me today? What is it trying to protect me from? And that allows you, that little bit of curiosity widens the space. It's an open question to actually say, well, what else could be happening that my nervous and immune system is feeling a threat? Because if you ask the question, what's wrong with me? It's a closed question. You cannot give a great answer. It only makes you feel more blamed and guilt and shamed. But when you say, what is it that my nervous and immune system protecting me from? that opens it out a little wider. It feels less blameworthy, less shameful, and gives you more opportunities for correction.
One part of the one part of the book looks at medications and interventions not always working the way people hope. How should someone with chronic back pain think about medication as part of their overall toolkit?
Good question. I think, given that it is the most common thing that everybody goes for anytime, here's the data. Let's put it this way. Here is the data, and I would call it 30-30-30, meaning that the best scientific evidence suggests that drugs, medications work in 30% of the people only. So only one third of the people. It works 30% of the time with 30% efficacy.
And that's the evidence, right?
That's the evidence on average. Any drug, stating from medical cannabis to gabapentinoids to opioids to paracetamol to codeine to tramadol to amitriptyline, it does not matter. The evidence kind of says that you have only about a 30% benefit in 30% of the people, 30% of the time. So, my simple question to a lot of my patients is, okay, if you want a medication, I completely understand. Let's try a medication, but it may work only 30% of the time and it may work only 30% efficacy. How can I help you for the remaining 70%? What could you do differently to manage the remaining 70% of the pain, the remaining 70% of the time? And that allows me to actually then have that conversation, because when I ask in that kind of open question, a coaching style question, to say how can I help, some of them may say I don't know, but some of them I would say, well, what else do you think has helped you in the past? And they will come up with some series of suggestions. And so my overall message is, medications are rarely the whole answer. What else can you add as part of the toolkit? And it could be a good support, it could be a bridge, it could be something you take as and when you require to enable rehab or movement or sleep or maybe engagement, to go out to do a good activity, with your partner, with your loved one, for going to a movie. You could take that medication for a shorter period of time, but ultimately it does not provide safety to the nervous system. What are you going to do to retrain the nervous system? What are you going to do to calm the nervous system down? And that is what I try to focus on. All the problems that have happened in the US and have happened in other parts of the world are when medications have been thought to be the only strategy, and you keep escalating that again and again without really paying attention to the wider toolkit that we have. And that could mean education, that would be understanding, that could be lifestyle changes. Just don't give medications the lead role. Make them as part of the overall band of brothers.
You also emphasize lifestyle factors like sleep, diet, and stress. For someone who's been told your scans look fine, why do those feel-good habits actually matter so much for pain?
It's a great question, because it allows me to expand on one more aspect of the new science. So I've already talked to you about pain and nociception and told you about that. Now, when we did medicine, when we all studied about pain in any of the healthcare schools, we were told that broadly there are two kinds of pain. There is nociceptive pain, meaning the kind of pain you get when you have acute pain or a surgery or injury. And then you have a kind of pain where the nerve gets damaged, like that's called neuropathic pain. And that can happen when your nerve gets cut during surgery, or you had chemotherapy for cancer treatment, or you've had some kind of medical condition like diabetes or Parkinsonism or multiple sclerosis where the nerves have got damaged. Now, for a long time, if you looked at conditions like non-specific back pain or neck pain, where the scans look normal, you have conditions like migraine, you have conditions like fibromyalgia, you have conditions of many types of pelvic pain where there's no endometriosis, you have IBS. Now, these conditions, there isn't an obvious inflammation or nociceptive pain in all these patients. There isn't any nerve damage in these groups of patients, but their pain is very real, and it is real because of everything I've told you up to now, because of the way the nervous and immune system gets hypersensitive. Now, that category of the nervous system getting overprotective and hypersensitive is a new category in itself. It's called nociplastic pain, meaning that the nervous system has become plastic. It's kind of changed and become more sensitive. And at this point of time, at this time in 2026, beginning when we're recording this podcast, there is no proven effective drug for nociplastic pain. There is no proven surgical technique for nociplastic pain. Nociplastic pain happens in almost every chronic pain condition, and indeed even conditions which start out like a nociceptive pain. So if you've had a acute flare up of your rheumatoid arthritis, or you have an acute flare up of your osteoarthritis, or sometimes your autoimmune condition flares up, over 3 to 6 months, one third of those acute pains will start to have a nervous system becoming sensitive. It will become nociplastic. In neuropathic pains like diabetic pain or in MS related pain, two-thirds of those patients will get nociplastic, the nervous system getting sensitive, which means your strategy is how can you calm the nervous and immune system down? And for those two questions, the treatment strategies that have come from other healthcare fields is that one of the best ways to calm the immune system down naturally is through nutrition. One of the best ways to calm the nervous system down naturally is stress management strategies and sleep management strategies and movement and physical activity strategies. Another excellent way to calm the immune system and nervous system together is a variety of mind body techniques, whether that's yoga, whether that's mindfulness, whether that is meditation, whether that is the behavioral techniques like ACT, acceptance and commitment therapy, or pain reprocessing therapy, or emotional awareness and expression therapy. But we have to look at all of these evidence based techniques and put it together to say this is how we calm the nervous and immune system down, which is why I think that these are not simple, nice to do things in chronic pain. These are crucial, as important as drugs and injections techniques to do in chronic pain.
You mentioned before about distraction, and it's very interesting because I have a new patient, and he told me he's dealing with chronic back pain, but whenever he goes snowboarding, he doesn't have back pain. And he was actually asking me why. Can you explain, or is it just a distraction?
One part may be distraction. The other way is actually to say, to him and to his nervous system and to his body, snowboarding is obviously something that his body feels confident and safe in doing. So that means his nervous system and his body does not feel like it's under threat when it goes for snowboarding. That would be one of the ways I would explain why what should sound like a very intense activity does not bring about any increase in pain. And I have patients of mine here who will say they are fine when they go skiing, but when they went for a run in their local park, the pain got worse. And I'd say, well, imagine how much of control and movement and threat I would find running much more safer for me than trying to ski on a ski slope. And I think it's a reflection of what our nervous system feels safe is also playing a part, I think, rather than just distraction alone.
So, your book includes real stories from people who've changed their relationship with pain. Is there one moment or story that gives someone listening real hope that change is possible?
Yes, there are many stories. I think while in the book for each of the chapters, my publisher told me, oh, you should have one story at the beginning of each chapter there. So there are about 6, 7 stories for the chapters in there. I think from all the patients I've looked after where I've seen dramatic changes happen, I think, and I would hesitate to say dramatic because I don't want to feel like I'm sort of selling something snake oily. It's more that turning point, it happens when they suddenly realize that they don't have to be afraid anymore. Yes, there are the people who make some meaningful changes in their sleep or in their lifestyle patterns, like stepping away from a stressful situation, moving away from a very toxic boss or a partner. That itself brings down the stress level, and they'll come back 3 months later and say, you know what, you told me that I have to do something about my stress, or there I did this thing, and I automatically noticed within 3 4 weeks most of my pain had come down. I was sleeping better. So it's often that one keystone habit changes, and then a lots of other things become more easier to do. Their sleep improves, their nutrition improves, they can start becoming a bit more healthier in terms of moving, they go out for a run, and it almost becomes a virtuous circle rather than a vicious circle. But overall, I think it's the quiet turning points. People stop chasing a fix because they realize there isn't anything to fix in their body. They start rebuilding trust with their body. And when they realize it, that I think is the biggest shift. And often that shift is when the person makes it themselves. That's where I feel the real value of sometimes the coaching approach that I've taken in the last 4 5 years. That is where I see the biggest changes, is when I have just said something, asked something, explained something in a different way, and the penny drops from them for them. And then I make a few suggestions and I see them in the follow-up 2 3 months later. I've seen a complete sea change. I don't know at what point the change happened, but by the time they come and see me, they'll say all of this changed. So thank you so much for saying what you did. I really felt much more confident and reassured and hopeful when I went out, and that's what I've done.
If movement hurts, how do you know what's safe to do and what's not?
Interesting question. I think discomfort or hurting movements again doesn't automatically mean that we are damaging something. So I encourage patients to look for sort of signs of safety, that does the symptom or the movement hurting thing, does it settle within a few minutes or a few hours? Do they feel that when they have looked back over the last 1 week, are they moving more than what they did the week before? Which means I use it to say, well, is your confidence better that actually barring this one movement hurting, you are moving a lot more in the last week? And I think if I can show them that the movement that they are doing while it is hurting is less threatening over time, that means they have made small, meaningful improvements in the right direction. It doesn't mean that movement should have zero pain. It just means that they are going in the right direction. It is getting progressively less painful. And that way, as you gradually increase movement, you have gradual reduction in pain. I ask them to say, okay, can you just mindfully track it? Just it's a form of somatic tracking there. So just be non-judgmental, see how it is, reflect on the fact that you are moving in the right direction. Don't worry about a small hurting part there, and let that be the lesson to your nervous system, that it's learning to be safe, learning to trust itself, and that motion isn't dangerous. And once that happens, the vicious circle will go away, the virtuous circle will kick in, learning will improve, confidence will improve, the pain will get much better over time.
How can someone start trusting their body again after years of pain and setbacks?
It's a challenging question. I don't think there's an easy answer, which is why I feel the most important thing is that therapeutic rapport and that alliance with their healthcare professional, whether that's a movement therapist, whether that's a Pilates instructor, whether that's a physiotherapist, whether it's a primary care practitioner. I think that therapeutic alliance is so helpful. Once that is there, then trust can gradually come back through consistent, gentle reassurance and evidence building with someone else. And sometimes it may not have to be an healthcare professional, it may very well be just another trusted partner. Could be a friend, could be a spouse, could be a sibling, could be a son or a daughter. But I think if we can get that combination of small pieces of evidence and small wins with a trusted relationship, then each of those small wins can be made to matter. And that means you have a walk that happened without things getting worse. You have a flare up that seemed to start but settled quick. A movement that was sort of tingy, twingly yesterday is now less painful and it has settled very quickly. And I kind of just say, okay, don't ask the question, will this hurt? And oh my God, let's not do it. Let's ask the question, well, what could be the safest way or a safer way to do this, and try it. And trust will grow each time they do it and they get better. And when the body experiences that safety again and again, it will say, well, you know what? I don't need to push through. This is just happening naturally. And that is probably the best way I can say that patients can or someone can start trusting their body again.
When does rest help? And when does it quietly start working against recovery?
Interesting question, really. I think it's, I can approach this from multiple angles, but I think my best way, so when I have helped out in pain management programs, these are group programs which we do with a physiotherapist, psychologist. Sometimes I step in to help out occasionally. A lot of time the work is done by my colleagues there. I think when we talk about rest, we talk about rest in the context of, does it help in building capacity? So think of it like the way, if your energy requirement for a certain number of hours in the day, you have like an electric car, you have a fully charged battery, and that's your energy capacity for the day. I think rest is going to be something that will be needed when you're starting to come towards the reserve capacity of the battery. If you can pace yourself such that you can take your body from morning to evening till you come back to get rest and recharge, that's excellent. But if the activities you do in a day are going to consume that energy faster, then rest is required in order to rebuild that capacity back again. I think it works against recovery. Rest will work against recovery when it's driven by fear. If fear is driving you to say, let's not do anything more, I'm just going to stop here because I'm afraid it will damage something, that is the time when rest can become counterproductive. And indeed, this is when people will start to get deconditioned. And then that means, from a threat perspective, your body and your nervous system is saying it's too dangerous to move. I don't even want to take the chance. Any attempt at movement can only just make things worse. It will only tighten up everything. And that is the vicious circle we want to avoid. So rest has a little bit of that double-edged sword in there. And I would say, let's look at the question: does rest help you return to life, or does it shrink it? Recovery comes from when you have cycles of rhythm. Move a little, rest a little, pace yourself, prioritize, plan for the rest, rather than completely stopping or constantly pushing.
I love it. I love what you just said. Thank you.
You're welcome. Thank you.
A big theme in your work is moving away from fear and towards safe, meaningful movement. So for someone who's terrified to move because of pain, or the mindset shift that makes movement feel possible again.
So I actually, in my book, when I talk about the movement or exercise chapter, I used exercise because the acronym comes nicely. But actually, what I wanted to move away was, the word often, exercise often makes pain patients worried that somebody is going to jump out at them in a lycra clad and tell them to do 10 reps of something. So that always worries my patients. So I talk about movement that feels safe. And I talk about the mindset for movement should be a growth mindset. So I think there's a lady called Carol Dweck, who talked about fixed mindsets. People, when they get stuck in one thing, that something is wrong, then there is no growth. And so I talk about movement from a growth mindset perspective, meaning that, can you move away from the fixed mindset that movement will damage me, to a growth mindset that movement can help retrain my nervous system? Movement can help build new nerve circuits that I can train. And if I can wire my nervous system differently by firing it differently, that wiring is going to mean protection and a better retraining. So I think that's the powerful shift I feel is, can you ask the question, can you tell yourself that affirmation, that this movement is helping me retrain my nervous system? And that is the message that I want to say, that when people stop seeing movement as a threat or a test of harm, and they start to see it as information, reassurance, then fear will go down. And that means movement is an experiment. You want to test something out and say, is it working? Okay, it has given me the information that this movement is not okay. So let's try this movement. So it's an experiment, not a judgment. And experiments are always going to feel far safer. It's sometimes just about the right words that you want to say to yourself at that time.
Can gentle graded movement calm the nervous system in ways people don't even expect?
Absolutely. Absolutely right. I would absolutely be of the opinion that that kind of gentle, gradual movements are going to be always a safer movement for the nervous system to experience. It's a powerful safety signal. That's why breathing as a movement is gentle breathing in and a slow, prolonged exhale. When you can breathe out for longer than breathing in, you are sending a powerful safety signal to your brain. When you take careful, gradual movements, that means your nervous system doesn't get the information that there is danger somewhere. And I think that, I would say, is any day better than doing 20 reps at intense, high intensity workouts. Is not the way. The nervous system will respond to consistency over time, not force. And when movement feels safe, meaningful, gradual, it can actually end up strengthening muscles in a different way. It quietens the alarm system. And when the alarm system quietens down, the threat quietens down, pain will also quieten.
That's what I usually say during my classes. If you feel like you're holding on to your breath, you're actually signaling danger to your nervous system. I have this, I jump online on my YouTube channel daily for 5-10 minutes, back pain relief exercises, and it's been really successful. I have people all around the world reaching out to me. And that's what I usually say every single day. Don't go
Brilliant.
too far. If you feel like you're holding on to your breath, you went a little too far. So you need to back off a little bit. Take the intensity back. Take a step back. You don't need to go that far yet.
Absolutely. Absolutely. That's really good. I think that's fantastic messaging.
Now, Dr. Ravindran, can you give 3 tips to the listeners? 3 tips how to manage their back pain starting today, or get over first 3 tips or 3 steps.
Well, I think first tip is try to understand your pain. Try to understand what your body is telling you. The second tip and learning point is that there is no correlation between your pain, the intensity of pain, and the structure in your body. And the third tip is be curious. Ask yourself the question, what is my nervous and immune system telling me to look out for today?
Thank you. Thank you, Dr. Ravindran, for your time. I really enjoyed this conversation with you.
Absolutely. No, it's been a pleasure as well. Thank you for having me.
Thank you. And thank you so much for the listeners to tuning into the Back to Movement podcast. This is all for this episode, folks, and we see you next time. Thank you.